We start in 10 minutes. Yes, we start in about 10 minutes. Hello, testing, 1, 2. Hello, Takahiro. Hello,
Hi, good morning. Good morning.
how you doing?
Fine, thank you. And thank you for inviting me today.
Well, yeah, I'm sorry about the time. I should have checked back with you.
Yeah,
Um,
but no
my
problem.
fault. My fault. I'm sorry.
And
So,
don't mention that.
well, we wanted to maintain contact with you and,
Yeah.
and, and with your group because I work with a dual neurosurgeon now, a hybrid neurosurgeon like you are.
Hmm.
And they have their own issues, the hybrid neurosurgeons, and we hope to gather them together to share people from other
Yeah.
parts of the world. What is hybrid neurosurgery and how is it being used by leaders in the field?
Mhm.
So
Yeah, I agree.
we uh, we televise mostly on YouTube, so that's where most of the people are watching it. Uh, they used to come in the panel, but most people now prefer to watch YouTube and they don't participate. Okay, let me hold on. Chat. We start in about 5 minutes.
Okay, I can wait.
Yeah, about 5 minutes, okay? Okay, we start in 3 minutes. Hello, Uday. How you doing, Uday?
I'm good, sir. Thank you.
Yeah, you
Very
have
interesting
an,
webinar. Are you good, sir?
okay, very good. Now you have you have another position. Okay, no, you
Very
don't.
interesting.
Okay,
Very
yeah,
interesting.
you're okay. You're okay.
Very interesting topic today.
The topic today is dual neurosurgery, hybrid vascular neurosurgery, with some case presentations by Takahiro Ota from Japan.
Very nice presentation.
Hi, nice to meet you.
This is Uday
Hello.
from India. Which part of India? You're from which part of India, Uday?
Yeah, I'm from Meerut, Dehradun.
Okay. Meerut, India. Takahiro, you're from Tokyo, right?
Yeah, yes, I live and work in Tokyo.
Big city.
Mhm.
And no
Yeah,
one
I went to India once, 2 years ago. Probably
conference.
yeah, and Kerala, the south part of India. It
Okay.
is a very good place.
Thank you.
Uh, yeah, I went to Nepal, which is not. It's like India. A lot of the food is the same as India, I'm told. And here's here, Ata, you on now? Ata, can you hear me? Hello, Ata. I'm just waiting to connect with. Hello, Ata. We're going to start in a minute. Just 1 minute. Hello, Ata. Perhaps not here. Okay, we'll start and I'll introduce you. Okay, Takahiro. You ready to start?
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the pleasure of having a dual neurosurgery webinar featuring Takahiro Ota. He's a hybrid vascular surgeon from Tokyo Metropolitan Center in Tokyo. And we'd like to have Ata Alim Bhatti. He's a neurosurgeon that's now associated with Neurosurgical TV, developing the dual neurosurgery channel. And he's going to introduce Takahiro. Good day, Ata.
Hi everyone.
Go ahead, introduce Ata. Introduce Takahiro, please. Well,
Yeah, hello everyone. Um, Welcome. We are live from Neurosurgical TV, and today we have our guest speaker from Tokyo, Japan, Professor Takahiro Ota. Uh, his topic of presentation is functional vascular anatomy of posterior fossa for neurosurgeons. He's a hybrid neurosurgeon and very prominent in his field, and we welcome him to uh, this presentation. Professor Ota, floor is yours.
Thank you for inviting me today. So I will share my presentation. Okay. Do you see my slide?
Perfect, perfect.
Okay. Excuse me. So good morning, everyone. I'm glad to have a chance to tell you about some of my recent work on the functional vascular anatomy of the posterior fossa, which includes simple basic rules of brain development. I'm Takahiro Ota, I'm director of Department of Neurosurgery at Tokyo, Japan. So look at this figure. I am not an embryologist. I'm a neurosurgeon, but I have the impression that people are a bit dismissive when hear the word embryology. Today's presentation includes some topics of embryology. I have one question. Why embryology is important for neurosurgeons and neurointerventionalists? From the embryological point of view, the basic patterns of cerebellar arteries development are highly conserved across vertebrates. So, embryology gives us essential keys to understand the pathogenesis of rare variants of disease. There are two key figures of my presentation. Left figure, what is black arrow showed, blue arrow showed, so do you understand what is? And the right figure, and what the right figure indicates. At the end of my presentation, you will easily answer these questions. So let's get started. This is an outline of my presentation today. I will first give a little background on the two basic arterial anatomy, longitudinal and axial, and then I will explain the development of basilar artery and primitive lateral basilar vertebral anastomosis and the cerebellar arteries. PLBA is one of keywords in today's presentation, and then vertebral artery perforators, posterior fossa veins, and the lastly, I have two questions for everyone. Okay, first, I will talk about basic arterial anatomy of posterior fossa. There are neuromeres which are morphologically identifiable transverse subdivision perpendicular to the longitudinal axis of the embryonic brain. First, three primary vesicles: forebrain, midbrain, and hindbrain. Then, five secondary vesicles are formed: telencephalon, diencephalon, mesencephalon, metencephalon, and mielencephalon. Finally, these other derivatives, metencephalon is changed to pons and cerebellum, and we call the hindbrain. Hindbrain means the pons and medulla in the other derivatives, and not includes midbrain. This slide shows the cross-section through the neural tube at different stages of formation of spinal cord and hindbrain. It's clearly shown that homology is preserved. This is the spinal cord, and this is a medulla, and this is a pons. In the hindbrain, both ventricles form dorsal, and in the pons, lombicularly formed, and this later changed to the cerebellum. Okay. I will show you the basic pattern of the angioarchitecture of the hindbrain. The perforators of the hindbrain follows the same pattern as that of the spinal cord. There are three types of axial arteries: paramedian artery, these are paramedian artery, and short circumferential and long circumferential arteries. The paramedian artery corresponds to the sulcal artery of the spinal cord. Short circumferential artery enters at the anteromedial portion, and the long circumferential artery enters the posterolateral portion. These two arteries correspond to the vasa corona of the spinal cord. Regarding the cerebellum, superior cerebellar artery and anterior inferior cerebellar artery and posterior inferior cerebellar artery are paired branches of long circumferential arteries, as shown in this slide. As you can see, the basic pattern of angioarchitecture of the hindbrain is similar to the spinal cord. We have longitudinal anastomosis at midline and lateral. We can explain cervical spinal and brainstem vasculature by longitudinal and axial arteries. I'd like you to focus on this green line, PLBA, and I will discuss PLBA next. Embryologically, upper part of basilar distal to the primitive tertiary artery belongs to the caudal division of the primitive internal carotid artery, and basilar artery is formed craniocaudally by midline fusion of longitudinal arteries. During embryogenesis, the ICA can be recognized, and it supplies the forebrain and midbrain via the olfactory artery and the anterior corridor artery. The olfactory artery gives off the anterior cerebral artery, and ilicerebral artery is a branch of anterior cerebral artery. And we have three carotid basilar anastomosis, trigeminal artery and hypoglossal artery for anterior artery between internal carotid artery and vertebral basilar arteries. And these transient carotid basilar anastomosis rapidly regress in about a week, and the posterior communicating artery, PICA, develops, and the basilar artery is supplied from the vertebral arteries finally. Okay, let's move on to the TRBA and the cerebellar arteries. Do you hear the word TRBA? Many of you didn't hear the TRBA. TRBA is primitive lateral basilar vertebral anastomosis. During development, look at the lateral surface of the hindbrain. You can see the two longitudinal anastomosis of channels, longitudinal neural artery and PLBA. In 1948, Paget described this anastomosis PLBA. PLBA is a temporary longitudinal anastomotic channel. And what is the role of PLBA? PLBA is a prominent vascular network, and there are many transverse channels between longitudinal neural artery and the PLBA. And you can see the PLBA is not a single artery. These are arterial network. Let figures show the embryo. The PLBA is supplied from the posterior branch of pro-atlantic artery, and cranially the lateral branches of the longitudinal neural artery, and partially the primitive trigeminal artery. White figure, and SCA is formed, and SCA the only cerebellar artery, and that AICA and PICA is not completely formed. AICA has only colloidal branch, and the PICA has no cortical branches. So SCA developed first, and AICA and PICA develops later. The important thing is the PLBA contribute to form these AICA and PICA branches. I will add a little more explanation about TRBA. This is the figure in rats. In rats, lateral longitudinal artery here. And Moffat, about 70 years ago, noted the lateral longitudinal artery in rats, which corresponds to the TRBA by Paget in humans. Yeah. So, I would once again, just to clarify the development of SCA and AICA and PICA. So, in the early stages, only the SCA supplies the cerebellar rudiment. Then, beside the SCA, the AICA and PICA have become more prominent in the vascular plexus that still cover the caudal hinterbrain. The point is, AICA and PICA develops later than supracerebellar artery. And the AICA and the PICA are homologous to higher branches of the spinal cord, and their origins from basilar artery and vertebral artery vary in each case. These arteries, AICA and PICA, are hemodynamically balanced, and dominance of these arteries, AICA or PICA, is determined by the relative demand from the developing cerebellum and brainstem. Supracerebellar artery. The supracerebellar artery in humans and other vertebrates, this artery is an extremely important artery, and there are no reports of SCA agenesis. The supracerebellar artery is a key artery in the formation of the midbrain and lumbencephalon, which are essential for ontogeny, including cerebellar peduncle, cerebellar and inferior colliculus for early development. Look at this figure, basilar tip aneurysm, and you can see the right side, two SCA branches. People can say SCA deprecation, but is this deprecation? It's not. In red, the Birmingham branch and hemispheric branch originate separately. These two SCA is not SCA deprecation, but separate origin of each SCA branch. These are SCA feeder supply the AVM. First, I navigate the microcatheter to the SCA roster trunk and inject onyx, and then SCA caudal trunk was occluded by onyx. Finally, nidus has come, and the vertebral angiography final showed after the SCA occluded, but collateral circulation from PICA or AICA cortical branch to the SCA area. So, SCA hemispheric branch has anastomosis with the hemispheric cortical branches. Let's move on to the PICA. The authors reported the morphogenesis of PICA with 3D-dimensional reconstruction in man. They show the PLBA is a large channel. This VBAN is a PLBA. It's not a single artery, it's a vascular network. So the origin of the PICA is not yet defined, and lateral medullary segment of the future PICA shows the topographic correspondence with the PLBA. So fenestration of basilar artery is another interesting point. Knowing the role of PLBA helps us understand the development of cerebellar arteries and the anatomical variation around the vertebral-basilar junctions. Okay, fenestration of basilar arteries here. Of course, basilar arteries formed from midline fusion of longitudinal neural arteries. You can see this two fenestration, basilar artery and vertebral artery, like this. Okay, look at this figure. MRI show the, from midline fusion of longitudinal neural arteries. You can see this two fenestration, basilar artery and vertebral artery, like this. Okay, look at this figure. MRI show the, from midline fusion of longitudinal neural arteries. You can see this two fenestration, basilar artery and vertebral artery, like this. mid-basilar artery stenosis, but this is series CT angiography, but we performed the angiography and 3D rotation angiography show the basilar artery fenestration at the origin of AICA. Okay, and the basilar fenestration have aneurysm in many cases, and the basilar artery is the second most common site of fenestration after anterior communicating artery region. Its frequency is about 1 to 2%. The incidence of basilar fenestration aneurysms is reported 0.3% of intracranial aneurysm. Look at this interesting basilar artery. If incomplete fusion of midline, incomplete midline fusion of longitudinal neural arteries, basilar arteries not fused, and we can see the two basilar arteries, left and right. And this case is a little bit complicated, but basilar distal basilar arteries are occluded, and the normal flow should pass through the PLBA to the basilar artery, and at the end of the hemodynamic flow, the aneurysm was formed. This is apparently this patient has basilar artery fenestration, but that's not correct. So really, I'll show this. This is a basilar artery, and the lateral, the patient has TRBA. So this is not the fenestration. Okay. And as I already told you, the PICA has large variability in its pathway as well as many its origin. For example, unilateral genesis, hypoplasia, double or duplicated, and epidural extracranial origin, like this. And this is a double origin of PICA, but this can be explained by the partial persistence of TRBA for the formation of this double origin of PICA. And of course, all of you have experienced to the patient with this AICA-PICA common trunk. The AICA and the PICA are complementary to each other. And this anastomosis can be explained by the partial persistence of TRB, common trunk, and partial persistence of TRB. Look at this case, 44 male and subarachnoid hemorrhage grade 5. 3D CT at initial show the aneurysm at VA PICA origin. But it's not a typical sacral aneurysm. And DST show the white road, something irregular artery between the AICA and the PICA origin. What is this artery? We didn't know what this was at before the treatment. And vertebral angiography 3D array showed this is the blue line PICA hemispheric branch, and the green line show the PICA Birmingham branch, and the orange line the AICA hemispheric branch. These are AICA and PICA branches, but this anastomotic vessels, what was the illustration showed that this part, but we didn't know this artery was, and we were not sure this artery could be sacrificed, so we clipped this aneurysm, and the post-orbital diffusion showed no ischemic lesion. And after the surgery, I investigated and searched the literature, and this is the example. The grades show the very beautiful figures about the common trunk of origin and the apparent origin of the three cerebellar arteries, SCA, AICA, PICA. Look at this, some anastomotic artery or common trunk in various types. These variants can be explained by the partial persistence of this PLBA. So our case can be explained by the persistence of PLBA, and this aneurysm occurred at the junction of vertebral artery and PLBA within. So this is a summary of PLBA. The angioarchitecture of the hindbrain is homologous to the spinal cord and includes two main longitudinal arteries, longitudinal neural artery and PLBA. Partial persistence of the PLBA explains the formation of commonly observed variations such as fenestration, duplication, and vertebral artery. Understanding the pattern and the development of the blood supply of the hindbrain provides useful information of the various anomalies of the vertebral junction and cerebellar arteries. And the third topic is vertebral artery perforators. Recently, quality of DSA images has improved dramatically, often difficult to stably visualize small perforating branches. And this is a schematic illustration of the basilar tip complex, basilar artery, SCA, PC, and PICA. So these are perforators. You can see the midline cranial fusion of basilar artery and midline caudal fusion of basilar artery. And you can see in some cases, arterial perforation. This artery supplies both terms from one branches. And anterior spinal artery and anterior medullary perforators from the union of the vertebral artery. There are important points: left-right difference, complementarity of the AICA and PICA. And if the PICA, look at this lateral medial segment. If the PICA originates from the intradural region of vertebral artery, the origin of PICA, proximal to the origin of PICA, there is no perforator to the lateral medulla. Look at this figure. PICA, anterior spinal artery originates from the V4. And the left figure showed this right side PICA, right side AICA PICA common trunk, and the extradural origin of PICA. This is anterior spinal artery. And if the PICA originates from the common trunk of AICA, the perforator is the lateral segment of medulla can originate from intradural V4, the durato union of vertebrae. Okay. And if this part, extradural origin of PICA, in this part, the PICA has the perforators to the lateral medulla. So this is the pattern of I showed you, the pattern of the origin of the perforating branches. But it's not related to the diameter, size of the vertebrae or PICA, and it's related to whether the origin of PICA originates from the same level on the left or right side. And about the anterior spinal artery, typically these balance type anterior spinal artery originate from both vertebral artery, but in some cases, right and the left anterior spinal artery are separated or only originate from one side. Look at the Rotan textbook. This is the both right side dominant, but both or have both origin. But in this case, right AC and the left anterior spinal artery are separate. So we need to pay attention to do parenteral occlusion of vertebral artery in case of vertebral artery dissection or vision of vertebral artery aneurysm. which anterospinal artery originates from which side. Okay? And this is the medulla and the perforated branch. It's a little complicated illustration, but the perforator originates from vertebral itself, or anterospinal artery, or anteromedullary artery. So we need to use this 3D rotation angiography or convex CT to visualize as many perforators as possible before making strategy to treat aneurysms around this region. Okay. So change the topic to venous system. This is venous drainage routes of brainstem. So there are two basic longitudinal and transverse veins in the brainstem, blue dotted line, transverse and longitudinal veins. How about the cerebellum? There are three basic drainage routes for brainstem cerebellum. First, superior drainage to vein of Galen. Second, posterior drainage to transverse sinus or trochlear. Third, anterior drainage to the superior petrosal sinus. There are three routes. This case has a conference dual hemorrhagic concept. You can see the feeder was the posterior meningeal artery, and the drainage pattern is superior Birmingham vein to vein of Galen to straight sinus. The complete occlusion was made with onyx injection. This illustration shows the veins in the mid-sagittal plane. And the blue line shows superior group, and the green line shows the inferior group. White figure shows a case with temporary dural wave, ICH onset, high resolution convex CT can be visualized this feeder and shunt and the drainage, venous drainage. And you can see the venous drainage, deculivar veins, culminated vein, preculminated vein, or placental vein to the vein of Galen, to straight sinus and trochlear. This case has our temporary dural wave. These are feeders, PICA and posterior meningeal artery. These are the drainage vein, inferior Birmingham vein, superior hemispheric vein. So this is the micro catheter injection. You can see the drainage route has two. Okay, then I injected NBC and completely occluded. Although there are many variations in the running course and the connecting pattern of the infratentorial veins, and understanding the basic patterns of infratentorial venous angioarchitecture can be beneficial for neurosurgeons and neurointerventionalists. So let's review the superficial veins of the brainstem. And I think you will get tired of seeing such a list of anatomical terms, but there is absolutely no need to memorize all the anatomical terms for easy understanding. Let us consider the venous anatomy of the posterior fossa in a simple way. First, this is anteromedial longitudinal vein. Okay. Second, this anterolateral longitudinal vein. Then there are lateral longitudinal vein. Okay, and finally transverse vein. Okay, longitudinal and transverse vein. I will show you one example, craniocervical dural AVF case, a symptomatic case. Let's consider the venous anatomy. And right figure shows the 3D images. These 3D images are useful for understanding and grasping venous structures, anterior posterior view and lateral view, and which direction in the drainage flows. I recommend you to examine the AP view and lateral view by side. For drainage route here. And these are the veins. But the cautery, anteromedullary vein to anterospinal vein, the cranially, transverse pontine vein to petrosal vein to SPS, and cerebellar vein to anteropontine vein, like this. Okay. And this illustration shows the vein of the lateral surface of the cerebellum, superior drainage group, anterior drainage group, and inferior drainage group. White figure these show the case with asymptomatic tentorial dural event. The important vein is lateral pontomesencephalic vein because this lateral pontomesencephalic vein connects supratentorial venous system and infratentorial venous system and works as a collateral venous flow. This is another case. Look at this photo, but it's not easy to which vein is superior or inferior or posterior drainage groups. So I recommend you to look at these figures, photo 3D and the conventional DS images side by side. So this is a superior petrosal vein, the space, then transverse pontine vein, anterior pontomesencephalic vein, and peduncular vein. And this purple, this lateral pontomesencephalic vein is here. And finally, superior drainage group, superior vermian vein, and placental cerebral vein. The summary of the posterior fossa vein, the superficial veins of the brainstem are divided into longitudinal and transverse veins based on their direction of flow. Longitudinal vein is continuous with basal vein of rosenthal crani and cautery to the spinal vein, and transverse vein connects to the longitudinal veins laterally. The cerebellar veins are classified into 3 groups according to their drainage route, superior, anterior, posterior. But many anastomosis or connection between each drainage group. Okay, lastly, the question for me is sacrifice or preserve. I'd like to discuss the posterior fossa veins from a clinical standpoint. First, can we sacrifice superior petrosal vein? This is an illustration of the cerebropontine angle, superior petrosal vein, and trigeminal nerve, and the SCA and the AICA. Superior petrosal vein was first described by Ota in Dundee, and superior petrosal vein is known as Dundee's vein or petrosal vein. And, this SPV drains the anterior aspect of cerebellum and brainstem. And on occasion, 2 or 3 superior petrosal vein on one side. Do you know what happens after superior petrosal vein sacrifice? This paper reported from animal models that cerebellum and brainstem edema occurs after sacrifice of superior petrosal vein. The cerebellum and the brainstem edema can be cerebellum and the brainstem edema can be observed at different time points using a rabbit model. And after sacrifice of petrosal vein, the previous reports that caused peduncular hallucinosis or cerebellar swelling, brainstem infarction, as you know, and the incidence of complication after sacrifice of veins varies on reports. And in another case, SPV sacrifice is unsafe, but I cannot believe this report, so we cannot predict what happened after the sacrifice of the petrosal vein, so we need to preserve the petrosal vein possible. My second question is about precentral cerebellar vein. Precentral cerebellar vein, it's belonging to the superior drainage group, and the superior vein drains into the precentral cerebellar vein. The united vein is called superior cerebellar vein. This drains into the great vein of Galen. Of course, this report showed after the supracerebral infratemporal approach, and they sacrificed the superior cerebellar vein. Of course, the hemorrhage in the cerebellum and massive edema had occurred. So, possible solution to minimize venous vein sacrifice risks: preoperative detailed venous workup and a tailored approach based on individual anatomy is needed. And to obtain some treatment course, other approach, tools, and modalities may be better. So let's discuss the prediction and prevention of the adverse sequences of venous sacrifice. Because to understand the factors that influence the result of venous sacrifice is important, and monitoring the safety of venous sacrifice. But this is not stable and not reliable. Third, applying surgical techniques to prevent of the adverse effects to preserve the veins. Fourth, stage surgery for the expected development of venous collaterals. This is also not reliable. In slow-growing meningioma, venous collaterals may develop. And fifth, reconstruction of the severe veins may technically feasible, but extremely difficult, as you know. Okay, so this is the summary of my presentation. So understanding the pattern and the development of the blood supply of the posterior fossa, longitudinal neural artery, and the PLBA provides useful information of the various anomalies of the vertebral junction and cerebellar arteries. Although there are many variations in the running course and connecting pattern of the infratemporal veins, understanding the basic pattern of infratemporal venous angioarchitecture can be beneficial for neurosurgeon neurointerventionalists when interpreting 3D rotational angiography or convulsivity. This is a final message from me. Let's enjoy learning functional vascular anatomy and neuroangiology. Thank you for your attention.
Okay, very good. Excellent presentation, good graphics. And it's fortuitous that I ran into you, Takahiro, because we just become associated with Dr. Ota Bhatti. He's a dual neurosurgeon from Pakistan by way of Switzerland. And I'm sure he has lots of questions, right, Ota?
Thank you, Professor Takahiro.
Yeah, thank you.
It's excellent, and I think it was very detailed, and it covered all the necessary areas. So I don't have any further question. I think if audience have any question, please. Okay.
Do you want to ask any specific questions, Ota?
Yeah, Professor, it's excellent. When you see your, I think it's anatomy variations. I mean, for example, deep venous anomalies. How often you come across those anomalies in your practice? And what are your key messages for attendees when they see any venous congestion? So how or venous varices, or how you interpret that in terms of high risk, medium risk, low risk, either DBA or any, coexisting two pathologies, DBA with, for example, posterior fossa, AVM. So how, do you go for functional studies? There is a discussion about awake confirmation of functions. So
Yeah, thank you for your comment. And first, I'd like to tell the attendees the importance of understanding of conventional DSA, because we see a lot of conventional DSA images, but in many cases, young neurosurgeons cannot realize this image has some anomalies or some anatomical variants. So the important is maybe this patient has some anomaly or variants. Keep in mind that information. So, of course, just run the images of the DSA does not tell us anything. So I usually repeat it, see the DSA images, and whether there is any variants or any anatomical variants or deformation or regression or anastomosis. So reading, understanding of imaging of DSA with interest is very important. And Ata or commented about DBA, developmental venous anomaly, but the DBA is another topic. So I think the time is limited. So I hope that we'll have next time to discuss about DBA in the near futures. And
sure.
today, you raised your hand. You have a
Yeah,
question.
Yeah,
Dr.
yeah,
Uday. Yeah.
thank you. My discussion
Thank
was
you.
just about the DVA, but you said like it's like another topic. I mean, DVA doing with the craniotomy is equally effective when doing an embolization, because like when you do a mini craniotomy for a DVF, we just buzz the vein and the whole DVA collapses. And like an embolization also, it is also a very sleek procedure. So how do you counsel your patients? What would be a better choice would for them to opt for an embolization or to opt for a mini craniotomy or something?
So
Yes,
you
very
mean that you embolize the development
Yeah,
of
I
venous anomaly?
yeah. DVF.
Drug AVF?
Yeah.
Okay. Okay. So, so what types of drug AVF should I comment about?
I mean, how do you
So,
counsel your patients to opt for a craniotomy or an embolization? How do you suggest your patients what to go for?
so treat or not treat?
No. Which procedure
No?
to opt for? To go for a
I
embolization
see.
procedure?
Of course, the drug AVF lesion can be grouped into sinus type and no sinus type. If this sinus type and we we when we can approach transvenous, the transvenous embolization is the first choice. But in some cases with non-sinus type dural AVF, in that case, transarterial embolization would be better using onyx, some like embolization, I think. And in the very short cases, we selected direct surgical approach. Of course, yeah, we have several cases.
Thank you. Thank you.
Sorry, the
Thank you.
discussion was diverted to DBA. I think Dr. Ota wants us to focus on anatomical variations, and so the posterior fossa perforators are something which are challenging for any sort of decision making, and I think the uh, the way the message is, we don't need to memorize the flow, the anomalies and the variations. So if we understand the flow dynamics, if we see, for example, the origin of perforators in asymmetrical basilar bifurcation. So in that, what is your recommendations for any interpretation of? I mean, what are the chances of variations you find in posterior fossa circulation? What is the commonest one, and what is the most important variation one has not to miss
Yeah,
when?
very important points. Um, uh, the DSA can show us many tiny small perforators recently using 3D rotational angiography or cone beam CT, but not. I think not all perforators can be visualized by DSA. So I'd like to stress both uh, precise DSA image and anatomical knowledge
Yes.
are important to find the important perforators before the treatment. So with the knowledge of anatomical variants or anatomical patterning of the perforators, lead us to find which artery is the perforator or which artery is the vein. So both the imaging and the anatomical knowledge is it's like both wheel of the car, I
Yeah.
think.
And do you comment on safety zones of perforators like in PICA? So are they consistent, or we see variations in that also? I mean, for example, the catheter-based intervention for PICA is when you are distal to the first loop.
Mhm.
Most of the, I mean, majority of cases, you don't see perforators beyond that. This is what the safety point of PICA is.
Mhm.
How variations, you see how common variations in that safety point, or is it a fixed um, in your population?
And I have no data with the perforator of the first segment of PICA, but
Mhm.
uh, if the neurointerventionalists often occluded the PICA, and vascular neurosurgeon often clips PICA, but and after the intervention, whether the ischemic lesion occurred,
Mhm.
uh, it depends on both the occlusion site and flow stagnation, I believe. So the diameter of PICA and the site of the occlusion, the residual lengths of the normal PICA, all affected the result, the intervention and the surgery. So the anatomical pattern is just one factor.
Thank you.
Is this answer to your question?
Yeah, thank you. So I think do we have any more questions from the audience? If not, then we can move to the next presentation.
Oh, excuse me,
Thank you, Dr. Ota.
Hello, excuse me. Let me just thank Dr. Ota. It's very late in Japan. And
Okay.
I really appreciate him coming and adapting. And we'll do anything for you, Dr. Ota. We'll do webcasts in Japanese if you want on dual neurosurgery. And we certainly welcome you back to Ota's group, which is going to be every week in dual neurosurgery. We're really determined to get this community going. And you're welcome to join at any time. We're likely to have a conference in about a month on just dual neurosurgery and have dual neurosurgeons hopefully from all over the world. And I'd like to say good night to you. I know it's late. So
Thank you very,
Thank you,
thank you
Dr.
very
Ota.
much.
Thank you.
Thank
Appreciate
you.
it.
okay, Ata, I'm sorry to interrupt.
No. Okay. So Dr. Ota has given a very comprehensive neuro anatomy of posterior fossa. So we are moving to another topic. So it's also the basic of brain AVM. It's angioarchitecture of brain AVM, which is a very important area. And we would go very basic to understand very common and essential concepts. As we know that the brain AVM are characterized by high pressure, low resistance vascular nidus created by a direct shunting of blood from the feeding arteries into arterialized veins, bypassing intervening capillaries. So AVMs pose a risk of spontaneous rupture. That's the major presentation besides the other like seizures or pressure effects. Uh, that's something Yashir Gill has given a statement regarding the angioarchitecturally hemodynamically complex systems, which we label as brain arteriovenous malformations. These systems of AV shunts with specific neurovascular relationships, a variable and unpredictable clinical presentation, and a dynamic and only partially understood natural history. This associated with a significant morbidity and mortality. So still AVM has not changed its behavior. So it's difficult to treat. It's challenging for patients, challenging for treating physicians, no matter how advanced we are in terms of different mode of treatments, but still it's a challenging disease. So another giant of the field of neurovascular, Juha Nisnemi, mentioned that the complex vascular lesion, which has a arterial blood flow directly draining into veins without intervening capillary bed. So in normal circumstances, what happens is that the arterial side goes to the terminal arterial end of the capillary, and the capillary has a vast reactivity and accommodability of the different parameters of perfusion. But in AVM cases, that capillary bed is being bypassed. So this complex vascular lesions has a arterial blood flow directly into draining veins. So that result into into lack of resistance in the small diameter arterioles and capillaries, and this leads to different arterial and venous pressure dynamics change. For example, markedly increased blood flow, dilatation of the vessels, tortuous growth of vessels. In addition to anatomic cerebrovascular changes, this process may bring in further challenges in terms of stealing of the blood from the destination territory, and also this can lead to reversal of venous flow, leading to venous hypertension and hypoperfusion, as I mentioned earlier. So this high venous pressure can lead to hemorrhage, which is a very overwhelming emergency. And if it's, for example, in a posterior fossa or it's massive, it can be fatal, and it can be the first presentation. So from the neurosurgical standpoint, so there is a phenomenal classification to identify the characteristics of AVM challenges, which we all are familiar, being given by the Spatzler-Martin in 1986. And that had three basic components: the size of the nidus, the allocance or non-allocant, and the venous drainage, either it's superficial or deep. So this five number grade is still relevant, famous, and a landmark. And you see different sort of other classifications which are beyond the scope of this talk. But I would like to mention the Lawton and Young. So that is also called as modified Spatzler-Martin grading from the same center, Barrow Institute. So these are the source of predicting complications in surgical decision making. Process become easier, and risk stratification leads to the mapping of the situation and planning of the surgery. So the Lawton and colleagues added what Spatzler-Martin grading already mentioned, was that it brought in patient's age, history of hemorrhage, and nidus type, in addition to classic factors. So that was very it's important, because many complications comes with the age groups, previous hemorrhage. So in routine, around 2 to 4% per year risk of rupture of AVM can become five-fold increase once there is a history of earlier AVM rupture. So the history is always important. So significant improvement in brain AVM and its understanding has been seen by the work done in last 2 decades or so. And now it's established that is increasingly multimodal, involving various teams in the process of medical care, diagnosis, interventions of different sorts, and post-intervention neuro ICU, and follow-up vigilant follow-up in post-operative situations for seeing the residual or looking at the post-operative challenges. So clinical and neuroradiological evolution, how it goes in near future, is very clearly going in the direction of genetic and molecular factors individualized to the patients. Clinical trials will assess individual responses to therapeutic options. So far, we don't have any genetic molecular or medical treatment for AVM. So gold standard is microsurgery, and very important contribution of endovascular neurosurgery as a complement, or sometimes exclusive way of treating these difficult diseases. In addition, there is radiation, which is being utilized in a multimodality fashion in selective situation. So the anatomical knowledge and geographical architectural analysis is very important. Understanding the flow dynamics, um, interpretation of concepts has led physicians, treating physicians, able to reach to a stage where previously labeled non-operable things are now possibly can be operated with acceptable risks. And this is where a multimodality improvement in every stakeholders has contributed. So there is two more most important things I would like to mention. One is better imaging facilities. MRI is very helpful initially to pick up the diagnosis, and giving a localization and type and the basic angioarchitecture, and then various forms of angiographic investigations, starting from the 4-vessel digital subtraction angiography, and then 6-vessel, and then going into more selective, more advanced to super selective microcatheter based studies to see the angioarchitecture of the AVM and its behavior during the catheter based interventions. So my mentor, Professor Valavanis, and Professor Tanaka has worked in AVM, and Professor Valavanis has still has one of the most leading in arteriovenous malformation studies, which he done on more than 1,000 cases in his era, with the most successful exclusive treatment, and the rate was more than 40.2% exclusive therapy successfully, and the complication rates were remarkably low in his hand, and it was 1.3% morbidity and 1.3% mortality. So the complex and only partially understood lesion was with a very variable natural history in individual cases. This has a significant morbidity and mortality. And this is coming from the pen of master, who has the most refined experience and most first in AVM treatment by endovascular exclusive therapies. And he was one of the innovator of micro catheter-based super selective angiographies. So still this disease, in his opinion, is very variable in person to person, and very complicated in terms of natural history and high risk situation. As we all know that microsurgical removal, radiosurgical obliteration, and neurovascular embolisms are the three standalone or combination therapies. So embolization is a very important addition to what microneurosurgery has had in previous treated patients. So as we see that the super selective microcatheter is a hunt from a very selective microcatheter based injections going into the feeder, precisely analyzing the vascular composition and intrinsic architecture of the nidus, which is the topic of today. And this requires for almost most AVMs we treat today in the operating room or angiographic suite. And to understand this disease, we have to understand the type of feeding arteries, their pattern of supplies, and vascular connections, as well as different nidal characteristics, whether it's compact or diffuse, it's a high flow or low flow, and morphology of vascular spaces, the characteristics of different parts of the nidus, the compartments, the different veins communicating to or not communicating to the compartments, and secondary or primary venous drainage patterns. So these are important to know before we go to the intervention site. And as MRI gives the basic idea, and the run of 4-vessel or 6-vessel DSA gives a fair idea of initial holistic picture of AVM, but the super selective gives the more fine details of the flow dynamics, the characteristics, and we also will see how the complete angiographic phenomena helps during the various decision making and the intervention. Like having a high flow will lead you to choose different sort of for example, if embolization is being done, what amount, what consistency, and those sort of things, the injection pressures, assessing the targeted embolization or partially targeted embolization. Sometimes you have to look into the highly risk factors first, which we will discuss in next slides. Here is the philosophy of Professor Yashigil. If you recall, his micro neurosurgical AVM experience comes in the line of the classification based on the phylogenetic paleopallium, archipallium. So these subpallium or neopallial divisions of the phylogenetic description of brain. So we'll just touch these things as we see that the paleopallium is the basic old 1 to 3 layers of brain cerebral hemisphere area, and it's a very rudimentary olfactory lobule which makes this paleopallium. And we know that olfactory bulb, olfactory tract, olfactory tubercle, intermediate and medial stria, anterior olfactory nucleus, part of amygdala complex, and preform cortex makes the paleopallium. And if we look into the different embryogenic developments and the localization standpoint. So the paleopallium changes into more advanced forms in an evolutionary way described described by the previous phylogenetic comparative studies. So the hippocampus, I mean, the initial one is the very basic part of the brain, which we see in the very basic species. Is usually the water fish species has paleopallial brain, and then the archipallium has 3 to 5 layers, and this is where the hippocampus rudiment, which changes from 3 to 5 layers, subcallosal area, body of column of fornix, mammillary body, cingulate gyrus, parahippocampal gyrus, and dentate uncus, and part of anterior insula composed of the archipallium. And paleopallium and archipallium, they both have allocortex. So they don't have the 6-layer composition of neopallium. So I would like to show you the importance of coronal images. So this is the there are the 3 main sulcus: circular sulcus, callosal sulcus, this, and here you see the collateral sulcus. So if you make a round circle, so anything which is in within this circle is paleopallium and archipallium, the old brain. Subpallium, in the form of this blue Putamens, substantia nominata, striatum, globus pallidus, caudate nucleus are the features of more motor activities and more reactivities, the different pathways, mainly the motor activities are being controlled here. And paleo and archipallium are more into the fear, fright, fighting, this sort of anger and the hippocampal memory formation. But what makes us different from the other species is neopallium, which is what we call as talon cephalization, makes our species as the highest species. So this coronal images of MRIs or during the angiographic studies. So these coronal images helps you localize the disease and also give you the neopallial gyral sulcal patterns on MRIs. For example, we see before doing the angiographic or invasive things, and we see how the different intrinsic diseases like not only vascular AVMs but also the glial, which follows these boundaries of phylogenetic, and at least initially it's very predictable vascularity. For example, the limbic system, or what comes into the archipallial brain, has a very predictable supply from the posterior choroidal part, and we know that the neopallial has we divide them into either pure sulcal or gyral or mixed type. So this is what we call as topographic classifications. So as we see that the in Zurich series, these are the numbers: 28% pure sulcal. When you see the picture here, the conal.
Oh
This,
my God, you're not sharing anything. I don't know, I was waiting for you to share things, but you're not sharing anything.
oh, really? Let me just see. Which next slide you saw?
Yeah, you're not showing any slides.
Okay, let me just
Okay.
let me see.
Screen share, yeah.
Do you see? No,
Not yet.
no.
No, you gotta click share.
No, no, I messaged. We
Hold
cannot
on a
see.
minute.
Okay,
Yeah,
okay.
click share first. Ata, share, okay. No, not Dr. Bhatti. Excuse me. You're gonna share, Dr. Bhatti?
Sorry.
Yeah, are you gonna share some slides?
Yes, yes.
Okay, you're not sharing.
I thought the slides are okay.
No, no, you never have been.
You didn't see any slide right from the start?
Now, from the start, we didn't. You're
Oh, okay.
you're in
Now you
control of
see.
the slides. I'm not control. You're in control. Okay, it's showing now. Okay,
So you see it.
now
were
we do. Now we do.
Yes.
Okay.
So this was a slide where I was describing Professor Yashir Gills and Johannes Nemes, and then the classifications by the Spetzler, Martin, and Lawton classifications. I was just highlighting the future of molecular and genetic studies. We also mentioned regarding Zurich experience and the way they look into the super selective utility in the AVM. And now we also saw the phylogenetic distribution of these paleopallium, archipallium, subpallium, and neopallium. I mentioned that there are the three very important sulcus: the callosal, circular sulcus, and the collateral sulcus. You see my arrow moving?
Yes.
Okay, so anything which falls into inside this circle is paleopallial or archipallial. This green is archipallial, the hippocampal, the paleopallium is olfactory lobe, archipallium is also more into limbic, paralimbic system, and neopallial or telencephalization is what which makes human species superior to other species. Very close behind are the chimpanzees and other less frontal lobe and less developed volume of the brain. So we have 17 billion of neurons in our brain. So you see the next slide, we talked about the telencephalic AVMs, the topographical classifications, how the shape of the AVM describes the telencephalic AVMs. So if the sulci has, I mean, this is the gyri, this is the sulci. If we are looking at the frontal lobe sulcal, pure sulcal AVM, we see normally the lobule has two supplies like the ACA, MCA in the superior frontal region on the cortex, on the convexity. So we see the medial branch coming from the MCA to the gyrus, and it runs over the crown of the gyrus and goes dip inside to the sulci. In the inferior sulci there is a inferior or descending sulci, and then it's ascending sulci, and on the contralateral side the branches from the either ACA or MCA, vice versa, they come from the other side, and there is a leptomeningeal collateral anastomosis between them. In normal condition there are many vessels, like you see the cortex in the grayish, and lighter color is the medulla of the cortex, and you see the sulci in which the AVM is visible. On the top it's a triangular cone-like which is in the sulci, splaying the both gyrus and giving rise to the cone-shaped sulcal telencephalic AVM appearance of what the Zurich series has almost 28% sulcal type of AVMs. And when they grow, they can breach into the U fibers. They go till the ventricles in certain situations in advanced large size. And the special thing about this sulcal AVM is when you look into, there are 3 to 4 types of the medullary or cortical vessels. One is going all the way deeper into the deep medulla, one to the layer, if we see histopathologically, 1 to 6. So going beneath into the medulla is the long medullary veins, long medullary arteries. There are some side arteries from the from the sulci. There are main arteries from the crown of the gyrus. They have nothing to do with this AVM in the sulci. But one thing is more important, and that these sulcal AVMs are notorious to get recruited by the extra dural branches from the external carotid arteries supply system, or the dural branches supply these sulcal. And if they breach into the U fibers, they can present with the seizures, they can present with the hemorrhage as well. The other types are the gyral AVMs, which can be again 3 types: pure gyral, subcortical, or gyral subcortical with extension to the ventricle system. So as we go down, the diffuse AVMs can present with ischemia leading to angiogenesis and leading to sometimes a lot of angiogenesis in the vicinity of AVM, which we called as the proliferative angiopathies. So subcortical AVMs in pure forms are very rare, 2%, and 3% of diffuse AVMs have a proliferative angiopathy. But these numbers are vary from different experiences, different series, and different centers and populations. So deep or central AVMs in the core have more subarachnoid. They can be fissural, cisternal. They may be the parenchymal intrinsic or plexal, like the choroid plexus, intraventricular mixed types, and etc. And when we see that the gyral AVM involves the gyrus. So it has a more tendency to be visible as a more advanced deficits in the very small AVMs, if they are on, for example, motor area or in the speech area. There are more fulminant presentations, and the gyrus if itself has involvement of various type of vessels, feeding vessels, which we mentioned in the next slides. But we can see it here. The vessels itself gives tiny multiple feeders to the gyral. There are very important M-passage branches, M-passage, which are not the terminal branches. They supply to the normal brain, but in the way they also supply to the arteriovenous malformations. And this is very important to recognize the pattern of feeding arteries. And there are the nidus has a different sort of appearance, either the high flow or low flow. So based on that, different compartments based on the primary or secondary supplies. Primary supplies take care of the major components of the flow, and the secondaries are the supplemental arteries, which contributes to the AVMs. There is always a question that is AVM a congenital or a acquired disease? So we are not going into the different classification and the types of the AVM, but to mention that the venous vein of Galen vein of Galen malformations are the one which are usually seen as a congenitally presented, but the vasculogenesis is a dynamic process, and it starts from the fourth week, as early as third week after the cardiac composition in the growing embryo, and by the seventh week the circulation becomes more like a vasculogenesis, and adult like the structure has been formed by the end of the eighth week, and it further expand according to the expansion of the brain especially in the telencephalon. And there are certain initial cranial distributions. There are primitive arteries. There are connections between the anterior and posterior trunks. So if there is a mutation in the earliest phase, it reflects what we call at the vascularity. When it starts in the neural tube is like a tube, linear tube, and it keeps on curving to form the cavities, 3 cavities, 5 cavities, and there is a metamoric distribution of neuromeres, and according to the growing brain there is vascularity. And you see in this slide by the Pia Lestonias describe this congenital versus acquired, that this is based on the genetic as well as environmental trigger. So his theory of the genotypic leading to phenotypic presentation has a very important role in understanding of AVMs. And as we see that if the vasculogenetic early embryo gets involved in this metameric phase, the disease is more diffuse. and more severe. And if we see it in a more elder, the genetic genotype is present, but phenotypically it can present late during the process of more focal angiogenetic wear and tear remodeling process. And what we see is that the regional, local and focality comes as the trigger hits late in the developmental or postnatal life. So this trigger is important. It can be in the form of some infection. It can be in the form of some environmental exposure, and the remodeling leads to a unifocal lesion, which is smaller if it hits late. So this is the mutation was present. It had a genotypic way to express, but the trigger brought that disease. So now we go to the angioarchitecture of different AVMs, like this lateral ICA, to see how the angiographic appearance is. Like in this sulcal AVM, which we mentioned, there are lateral ICA angiographic view showing nidus, the superficial vein. We can not be sure of the other small components, the compartmental distribution, but we see that the major primary vessels are being more wider in diameter, and it's indirectly showing the more blood flow going through these primary feeders. We see this this very diffusely enhancing nidus, and the cortical vein draining into the central sulcus. And to look into the nidus of brain AVM from the superselective perspective, you see a dilated, so you see some sort of the arterial feeder, which are the feeders en passage, and these are the tiny, probably the neogenetic perinidal angiogenetic components, but you see the small compartments, and the other veins also visible. You see the arteries are tortuous, the veins are reddish, and this schematic gyral presentation showing the corkscrewing of the vessels indirectly reflecting the high pressure, and different corticomedullary distribution can be seen, as well as the nidus with a very tortuous, and it's giving the super selective parts of the blush on one or two vessels mainly. So in generally, if the feeders are 1 to 3, the risk of interventions are less. If the feeders are multiple, if there are more bigger nidus, if from the microsurgical point of view, if there is a deep venous drainage, if there is a deeper lenticular striates and perforator systems involved, these are the high risk situations. But before going into the super selective angio gives you an idea of the different behavior of the compartments, the inter compartmental venous system, the tortuosity, the intranidal weak parts. Yaki's AVM classification system in 1986 with a publication mentioning the cracking the code of curative embolization, mentioned that extremely challenging lesion with the congenital. Sorry? Sorry?
I didn't
Okay.
hear anything.
Any question? Anybody wants to ask anything? Do you see my slide?
Go ahead.
Okay. Now I'm on the compartmentalization of the nidus. Do you see my next slide? The Yaki's AVM classification system.
Yes.
Okay. So, at times you can see the AVM like something very asymptomatic as a birthmark. And again, Professor Lasjanias has metameric theory and the metameric syndromes described by him in the form of CAMS 1, CAMS 2, CAMS 3 had some sort of skin hemangiomas as a just only sign of these hidden posterior fossa pathologies, which later on diagnose based on what you see on the skin. You can suspect that, and you can essentially do the MRI brain to find out the details of hidden part of the same neuromeric presentation or metameric presentation of the extension of these skin malformations into the more inside, more hidden AVMs or other abnormalities. So in small child, like the vein of Gannon malformations, it can be very advanced right from the presentation in the form of congestive heart failure and melting brain syndromes. And this was Yakis described the abnormalities. Many patients, and this holds true even now in many places of the world, that patients seek different opinions, but they don't get the right diagnosis. They go, they either get the repetitive examination, misdiagnosis, and definitive therapies are either lacking or somehow not being able to be done on a scale which is now present in main centers in the higher income countries. And this leads to many of these AVMs presenting as the hemorrhagic AVMs or very advanced AVMs. So he described the different types. Type 1, where the direct high fistula, the arterial and directly draining into the vein, multiple arterial feeders leading to the and defined nidus, or many type of the vessels draining into one vein or multiple secondary veins, or more complex type of advanced large. So this classification had 1 to 4 grading depending on the severity and complexity of situation. As I mentioned, direct arteriovenous fistulas, multiple inflow channels, multiple arteries, type 3A, type 3B. And when we see the endovascular treatment arm, so it's not necessary that it helps or it stops endovascular treatment, because with the catheter you can reach to deeper niduses and deeper feeders with a very undisturbing way to the normal brain parenchyma, unlike to the micro neurosurgical. And even as an adjuvant, this knocking out of some feeders, treating the targeted high risk situation like intranidal aneurysms before going for microsurgery, as this is the gold standard. So the combination or exclusive mode of therapies can lead to the better treatment of these lesions. So one of the expert in the field of endovascular, Professor Reni Chappe, this published this main teaching points, and he has given this concept that representation of brain AVM in many teaching forums, in many teaching articles and books, is like this jumble of nidus, but it's not true in the real world. These drawings are never exist inside the brain. The nidus can be like corresponds to dysplastic multiple vessels along the wall of the draining veins, and identifying it in the this angioarchitectural connections of veins and arteries and nidus details is very important when you this gray like embolization material. So you see that when you start knocking out these vessels, the feeders, you see that the reddish venous appearance get the less flow, and resultantly reddish arterialized vein converts into the into the more bluish, more normal veins. But the philosophy of treatment is you have to keep this uh, this major draining veins preserved, and these understanding of flow would make you able to decide when this is the venous side of the disease. So you have to go into the venous side of the disease, but dealing all the compartments and dealing all the high risk areas, and preserving the draining vein until the last moment. And there are now described techniques of these injections, like in onyx and the other embolization materials in the form of pressure cooker, or the Zurich series, and other gold standard embolization material. NBCA has a different penetrations, and they can take care of these only when we understand the feeder types. As I was mentioning, that these are the terminal vessels supplying to the nidus, and but the lower one has the terminal supply to the normal brain as well. So you cannot just knock out these vessels. Uh, Otherwise you will face the ischemia and consequences. So preserving this veins, the importance of distinction between primary and secondary veins is very important when you treat. And the nidal vessels connected to this primary vein is being remained till this injection, dealing the two compartments. So the feeding arteries can be the superficial cortical, they can be the superficial medullary arteries, they can be the arteries from two different circulation, anterior cerebral or anterior and middle cerebral, or they may have a lenticular striate, the deeper connections leading to the more complex situation in gyral or gyroventricle AVMs, in which the lenticular striate systems or perforator systems also give either supplementary supplies. And when we study the MRI and other angiographic architectural system, we have to make sure that these perforators, deep perforators, such as the medial and lateral lenticular striate, may be coming from the anterior cerebral or middle cerebral, thalamoperforating P1. These are very well understood before we go for any active treatment step. And this is the part of the more high risk vessels in the form of more complications in case if they get knocked out during the treatments, and they may lead to more drastic consequences. So to repeat this in the words of Yashigil, the venous side condition of straight sinus or venous drainage patterns, like we see stenotic or occluded compromising venous system of outflow, can lead to more high-risk situations presenting or impending to the hemorrhagic presentation of AVMs. So identifying this venous supply is important. Diffuseness of nidus and a bigger nidus makes the AVM more vulnerable for complications, and this is how the Spetzler-Martin grading also clearly defines the higher number, the higher grade, and the higher complications. So the starting from 4 to 5, the complication rates drastically go very high. So a long course bile vessels, nidal venous aneurysms, and deep perforating systems, tortuosity of the vessels. These are all the high risk factor and features of these angioarchitectural details of brain arteriovenous malformations. So again, the reinforcement of the coronal images in localization, in understanding the different AVMs, their diagnosis, whether they are sulcal, they are gyral, what the feeders are, what the location is, if it's the choroidal system involved, the limbic vascularity loop is involved, what type of feeders are we dealing, and this coronal images are very helpful guideline before we go to invasive radiation based DSAs. And we do DSA and more hunting of super selective only when we have decided to intervene, before that we make sure that we understand it fully. So AVM treatment is a multi-model and evolving, and this is how the subtypes of AVMs are being diagnosed. And you see the dilatation of these feeding vessels due to the high pressure, high demand, and the stealing of this flow to the nidus. And you see the tortuosity of this big vessel in the occipital region in this lateral ICA angiogram. So this again shows the normal variation, the complexity. For example, the middle cerebral artery lenticular striate patterns are different. You can have multiple lenticular striates origin from the whole stem. You can have 2 or 3, 2 to 5. You can have more than 12. You can have just single or 2 lenticular striates. You can have lenticular striate coming from the anterior cerebral artery. There are variable trunk formation. You see the different ophthalmic artery, different temporal. So the main MCA patterns are trifurcation, bifurcation, but you may have uh, just single trunk supplying all the 12 vessels, like the orbitofrontal, frontopolar, and these parietal, central sulcus, and temporal branches. You may have these superior trunk supplying till the parietal and frontal and central lobe, and angular, uh, occipital, occipital and temporal branches coming from the inferior trunk. So this you have to examine fully before you go to the next level of management. So the location of AVMs also can be divided into supratentorial and infratentorial, and within the supratentorial AVMs, you may have again amongst the 86% of supratentorial, predominantly more AVMs in the supratentorial. The neopallial malformations can be sulcal, gyral, or mixed in almost half of the cases. You see the archi and paleopallial AVMs in 1 in 10 in the supratentorial, in the location-based classifications. Again, you may have a combination of pure sulcal, pure gyral, or mixed, or a bigger one having an extension to the ventricular with some sort of lenticular striate or deeper tiny perforator supply coming and making the AVM more demanding for any modality of treatment. So deep central AVM can present with the fissural, parenchymal, or plexal intraventricular, and vein of Galen malformation is pediatric AVM. 3% of the Zurich series. Infratentorial AVM can be neo-cerebellar, paleo-archicerebellar, and deep brainstem involvement with the intraventricular extensions. So these are the infratentorial and almost the 15%. So before going to the angiogram, there are more CTA-based 6-dimensional reconstructions. And this is what is from the Professor Eaton Ross 6-dimensional reconstruction of large right hemispheric. These, like the rotational angiographic images from the two biplanar sources, leading to more flow dynamics details. You see the central and the peripheral supply in a form of MCA, ACA, and the aneurysm, and how the aneurysm is either sumping showing the sump effect and making the some ischemic flow on the other territory, and how the aneurysm has in different dimensions, like you see the intranidal aneurysms in this. So that gives a very fair idea of the details. And in this digital subtraction angiography, the cone beam CT is also very good in modality during the intervention or during the mid stage of the treatment while doing endovascular or microsurgery, to make sure how the residual deeper AVM can make sure will not persist. And this shows the intraoperative details of, for example, glue or nidus excisions. And these diagnostic angiograms are very important to show the venous drainage patterns. Here you see the nidus, the superficial venous drainage, and you see there is a narrowing of the vein at the terminal sinus, and also the nidus having the deeper tiny vessels which were not seen in the normal runs of MRA or conventional angio runs. Similarly, this basal, this brain AVM showing how the feeding vessels diameter is compared to the normal vessels in the MCA territory, and it's showing some perinidal angiogenesis, nidal aneurysms, and the super selective catheter. You see this tiny wire going into the more advanced, more closer intranidal look, seeing the fistulous connections, and this can be done only by the microcatheter study, super selective study. So the indicators of venous outflow obstruction, as we see here, the venous phase of the frontoparietal brain AVM, any long PL drainage shows the high risk situation. The high venous outflow leading to the back pressure and the increased long course of PL vessels visible on the angio. You can also see the tortuosity and the pseudophlebitic beading-like appearances pattern, which again shows the compromised obstructive congested venous flow. Here you see the more prominent stenosis and tortuosities and blockage of the veins, and this shows that this is the high risk for symptomatology and bleed, because the primary vein has no drainage sinus, and there is a reverse flow leading to the brain parenchymal and PL vessels pressure increase and leading to the venous ectasias. And here you see in the D the venous aneurysms. And likewise, the Timo Krings in his publication shows the high flow components as the very fragile thing, and obliteration of this is a priority, and this targeted embolization in these central sulcus AVMs are mandatory to prevent its hemorrhage. So the DSA showing the venous face and the tortuosity of ICA injection leading to the PL vein appearances and showing the high venous situation. Professor Tanaka has shared this limbic AVM. You see the anterior cerebral artery, the distal ACA, the nidus of the aneurysm, treated, and post-treatment. And here you see the straight sinus filling up, the trochlear visible, and post-treatment is showing resolved nidus. The ACA back to its normal size compared to this dilated ACA. Post-treatment ACA is very normal size compared to the other frontal and parietal and callosal branches. And you see the nidus has gone, and there is no venous seen in the post procedure arterial phase. So these were the details of the aneurysms, and just giving you an idea of paleopaleal, archipaleal, and subpaleal development of the brain in different species, leading to this phylogenetic process of neomammal brain, which has a cervical flexure from cranial to the cervical, cranial to the caudal migration of the bulk of growing brain, and from the temporal to frontal opercular formation in human, and these subpaleal features. And this ventricle is different than the big ventricle in the primitive species, like in the fish, in very simple ventricles and few. And every mammal has this pattern of some sort of telencephalic insular based opercular growth of neopallium, and these leads to the development of the normal vasculature according to the growing brain size. And this is what the hemodynamical theory suggests, that the demand of supply leads to the more angiogenic procedure. And this is showing the growth in the operative armamentarium of microsurgical world, where you see the virtual reality giving you some idea of the vascular condition you are dealing in the microsurgical way. And these are the advancements, but remember that the basic things are first and fundamental to understand the localize, and to have that basic neuroanatomical knowledge make you more safer clinician. And this is the modern setups, the hybrid suites, where you can have the modalities complementing each other. Thank you so much for your passion, and I will stop here, and the forum is open for further discussion and any questions. Thank you so much.
Okay, very good. Thank you, Ata. Uday, you have a question? Go ahead.
Just a discussion from discussion point of view. Sir, like in sulcal AVMs, small sulcal AVMs. So if we go in just surgically, if we just go in transsulcally, not transcortically, how would you rationalize between embolization or or a small minimal invasive craniotomy for something like a transsulcal AVM, where we don't destroy the cortex and the functional outcome of the patient?
Uh, okay, can you see my screen?
Yes.
Yes, sir. Yeah.
Okay, so you're talking about
Yeah,
this
yeah, 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 exactly.
AVM type 1, very nice.
Yeah, just going transsulcally and
Um,
take out the, it will be a,
yes, yes. The
what
discussion
would be,
is the discussion is making this forum as a dual neurosurgeon
yes,
from
sir.
the perspective of patient is whatever is
Yeah, exactly.
safe, whatever is available, and whatever is minimal risk situation for patient. So at
Yes, sir.
times when we are just micro neurosurgeon or just endovascular, we are little biased to that
Yes,
special
exactly. Exactly, sir.
strength. And when we talk about these AVMs, yes, you are right. If we have a sulcal, they are very good to treat in both ways. If they are the low grade, and
Yes.
if your expertise are okay, if the situation is not high flow, in high flow selective large
Yes, sir.
sulcal which are going deep towards the more medullary and ventricular side, then you may have point to have adjuvant endovascular embolization first and then combine therapies, or it depends what
Yes,
your
sir. Patient to
all
patient.
right. Yes. So
Thank you,
it
sir.
should be our decision should be patient-centric, not biased
Yes.
to our
Oh,
strength.
yeah. Like I do both, and this is a very good option, like you told, to put forward both the options to the patient. Thank you, sir.
Exactly. That's the
Thank you,
strength.
sir.
That's the
Thank you.
strength.
Okay, very good. Any other questions from the panelists or comments? Rohan, are you there?
So it's not only the treatment, it's also this sulcal. If we identify it, we can anticipate where the feeders are coming from. And are they sharing to the, I mean, if they are sharing to the normal brain, or they are just draining to the uh, nidus only. So if the feeders are single or double, that sulcal AVM is less risky. If there are tiny multiple feeders with non-terminal pattern and passage vessels, then definitely it's more demanding and it needs more super selective analysis before we go to any modality. Thank you.
Okay, we have a comment or question by Rohan Mani from India. Rohan, are you there?
I apologize for initial this slide problem. So I hope you got grasp.
Yeah, sometimes I assume that the presenter knows Zoom well, but I guess
Yes.
couldn't tell. Go ahead, Rohan.
Yeah, the lecture was good. I was listening it, but missed a bit of the parts. But yeah, good presentation. Thank you for the lecture.
Thanks for
Thank you.
coming, Rohan.
Yes.
Okay, very good. Okay, that wraps it up. Thanks everybody for coming. Thanks, Ata. We're not sure when we'll have the next one. I think we're gonna have another one next week, but we'll be talking about that. And we hope to see you all there. So,
Thank
adios.
you. Thank you.
Yeah, the NIDAS classification and the Yasargan classification were some of the new things to me as a student.
Okay.
Oh, okay, continue on, Rohan, if you want to ask any questions.
No. Just a comment that the Yasargil classification, which I was aware of him as the father of microneurosurgery, and today I got to know what like it means. Basically, what is his definitions, and about some things about the classification of nidus, what different types of nidus we have. So yeah, in the aneurysm section. So yeah.
Do you want to comment on that, Ata? No.
No,
Uh,
I think. Mm,
Okay, very good. So we'll see you
Okay.
the next time.
Okay,
Yeah.
thank you.
Thank you. Thank you.